points. Part 16, Start of 3. In this part, I'm going to talk about what is next and is it the least aggressive. In addition, I will mention some special considerations and errata. I will start with what is next. In order to answer this question, we have to remember this flow chart, and we have to remember the directions of the arrows. Whenever the vision is good, we can go to aiding measures, or we can go first to corneal remodeling in order to regularize the cornea, and then we can follow this by aiding measures. And when the vision is poor, but the potential visual acuity is good, we can go to corneal remodeling followed by aiding measures, or we can go directly to contact lens fitting. And when the vision is poor, with poor potential visual acuity, the solution is corneal transplant, followed either by aiding measures or by corneal remodeling, which can be followed later by aiding measures. Now, this question, what is next, leads us to another 3 questions. What is the sequence of options? Can we reverse the directions of arrows? And where is corneal cross-linking in this flow chart? Let us start option by option, starting with the contact lens. Now, let us assume that the best option was for a patient to fit contact lenses. After that, we want to change or to switch to other aiding measures like glasses or phakic IOLs. So is it possible? Yes, of course, it can be possible. We can use glasses instead of contact lenses whenever vision is good, and we can go for phakic IOL whenever the refractive error is high enough to implant a phakic IOL. But if the option was corneal cross-linking first, followed by contact lens fitting, can we go for glasses and phakic IOL? Yes, of course, we can. We can switch from contact lenses to glasses, but if we want to switch from contact lenses to phakic IOL after cross-linking, then we have to wait at least 12 months after cross-linking to get accurate K reading before doing phakic IOL. So we have to wait 12 months. Now, if the option was contact lenses, and then we wanted to do corneal remodeling procedures like laser vision correction or intracorneal rings, is it possible? Yes, of course, it is possible. But if the option was corneal cross-linking followed by contact lens fitting, and later we want to switch into laser vision correction or intracorneal rings, is it possible? Actually, if we do corneal cross-linking followed by contact lenses, and later, for any reason, we want to do laser vision correction, we have to repeat corneal cross-linking. So this is very important. If we want to do laser vision correction, we have to repeat corneal cross-linking. And if we want to do intracorneal rings, it will be very difficult after corneal cross-linking with unpredictable results. Now, let us say the patient is fitted with contact lenses, and for some reason, we want to switch into lamellar keratoplasty or penetrating keratoplasty. Is it possible? Yes, it is. And it is possible even if we have done corneal cross-linking before. So, tell your patient if the option is corneal cross-linking followed by contact lenses, intracorneal rings will be difficult afterward. Tell your patient if the option is corneal cross-linking followed by contact lenses, corneal cross-linking should be repeated if laser vision correction is planned afterward. Tell your patient if the option is corneal cross-linking followed by contact lenses are best fitted after 3 months post corneal cross-linking. What about glasses? If the patient is happy with his glasses and later we want to switch to another aiding measures, is it possible? Yes, it is. We can use contact lenses and we can use phakic IOL if it is indicated. But if the option was corneal cross-linking followed by glasses, can we go for contact lenses? Yes, we can. And if we want to go for phakic IOL, we have to wait at least 12 months after corneal cross-linking in order to have stable K-reading measurements. Now, if the option is to go for glasses and later on the patient or for any reason we want to switch into laser vision correction or intracorneal rings, is it possible? Yes, it is. But if the option was to go for corneal cross-linking followed by glasses and later on we want to do laser vision correction, we have to repeat corneal cross-linking. But if the option is to go for intracorneal ring, then we have to know that it will be difficult with unpredictable results. Finally, if the option was to go for glasses and later on for any reason we have to switch into corneal transplant, it is possible, even if corneal cross-linking has been done before. So, tell your patient, if the option is corneal cross-linking followed by glasses, intracorneal rings will be difficult afterward. Tell your patient, if the option is corneal cross-linking followed by glasses, corneal cross-linking should be repeated if laser vision correction is planned afterward. And tell your patient, if the option is corneal cross-linking followed by glasses, glasses are best fitted after 6 months post-op. This does not mean that the patient will stay without any correction. He can use glasses, but the numbers or the power of glasses will change until 6 months. Now, if we want to go for phakic IOL, can we do any aiding measures after phakic IOL implantation? Yes, we can. We can improve vision by using contact lenses or glasses. But if corneal cross-linking was done 12 months before phakic IOL and later we want to fit contact lenses or glasses, is it possible? Yes, it is. Now, if we implant phakic IOL, can we do corneal remodeling measures after that? We can do laser vision correction with corneal cross-linking after phakic IOL, but it is unusual to do intracorneal rings after phakic IOL. Why? Because usually phakic IOL is indicated when the irregularities are not high, while intracorneal rings are indicated to regularize the cornea in cases of moderate to high irregularities. And if corneal cross-linking was done 12 months prior to phakic IOL implantation, can we do laser vision correction later? Yes, we can, but we have to repeat corneal cross-linking. And regarding the intracorneal rings, it is unusual to do intracorneal rings after phakic IOL implantation for the same reason that I have mentioned, and because corneal cross-linking was done before. And finally, is it possible to do corneal transplant after phakic IOL? Yes, it is possible, even with corneal cross-linking was done before, but this is very unusual to do corneal transplant after phakic IOL implantation. So, tell your patient, if the option is corneal cross-linking and phakic IOL, the latter will be done 12 months post corneal cross-linking for the stability of K readings. Tell your patient, intracorneal rings is not done after phakic IOL. Tell your patient, if the option is corneal cross-linking followed by phakic IOL, corneal cross-linking should be repeated if laser vision correction is planned afterward. Now coming to laser vision correction. Of course, laser vision correction in ectatic corneal diseases is always accompanied by corneal cross-linking. So, can we do aiding measures? after laser vision correction, yes, we can go for contact lens fitting, we can go for glasses, and we can go for phakic IOL. Now, if we do laser vision correction with corneal cross-linking, can we go for the other corneal remodeling option, which is intracorneal ring, including myoring? Yes, we can, but it is very unusual to do this. Usually, laser vision correction is done for mild irregularities, while intracorneal rings and myoring are done for moderate to high corneal irregularities. For any reason, can we go for corneal transplant after laser vision correction with corneal cross-linking? Yes, we can, but again, this is very unusual. So, tell your patient, if the option is corneal cross-linking with laser vision correction, contact lenses are best fitted after 3 months post-op. It does not mean that the patient will stay without correction during this period, but we can do contact lens fitting after 1 month, but maybe the contact lens properties will change after that. Tell your patient that if the option is corneal cross-linking with laser vision correction, glasses are best fitted after 6 months post-operatively. It does not mean that the patient will stay without any correction during this period, but he can use glasses and later we can change the power. Tell your patient, laser vision correction with corneal cross-linking can either be done 6 months after or 12 months before phakic IOL. This means that if we go for phakic IOL and we want to follow this by laser vision correction, this can be done after 6 months. And if we want to do laser vision correction with corneal cross-linking and then we plan for phakic IOL, this can be done 12 months after laser vision correction with corneal cross-linking in order to get accurate measurements of K readings. Tell your patient, laser vision correction with corneal cross-linking can be done 6 months after intracorneal rings. So if we want to do intracorneal rings followed by laser vision correction, this should be 6 months after implantation of intracorneal rings. And it's very important to remember that laser vision correction with corneal cross-linking is not done before intracorneal rings because each one has its own indication. Now we come to the option of intracorneal rings including myoring. Can we go for aiding measures after that? Yes, of course. We can go for contact lens fitting, glasses, or even phakic IOL when there is still high refractive error. Now, in some cases, corneal cross-linking is indicated with intracorneal rings. Of course, we know that we have to do intracorneal rings first, followed by corneal cross-linking at least 3 months after the implantation. And then, if we want to follow that by aiding measures, it will be possible. But if phakic IOL is to be done, it should be 12 months after corneal cross-linking to have stable and accurate measurements of K reading. If intracorneal rings is to be followed by laser vision correction, this will be possible. And if corneal cross-linking was done for any reason after intracorneal rings and later on we want to do laser vision correction, then we have to repeat corneal cross-linking with laser vision correction. Finally, for any reason, if we want to follow intracorneal rings by corneal transplant because intracorneal rings failed or there was protrusion or for any reason, this is possible even if corneal cross-linking was done before. So, tell your patient, intracorneal rings is not done after phakic IOL. Tell your patient, intracorneal rings is not done after corneal cross-linking. It should be intracorneal rings before cross-linking with at least 3 months apart. Tell your patient, intracorneal rings is not done after corneal cross-linking with laser vision correction. Finally, we come to the last models, the corneal transplant. After corneal transplant, of course, we can go for aiding measures, or even we can go for corneal remodeling measures, except intracorneal rings. We do not do intracorneal ring implantation on a corneal transplant. So tell your patient all options can be done after transplant except intracorneal rings. By this, we finished answering what is next. Now I'll move to the third question, which is it the least aggressive? To answer this question properly, I will give 7 examples. Let us suppose that there is a patient with good vision, high refraction, progressive disease, and he is tolerant to contact lenses. And depending on the other parameters, we find that there are 2 options. Either to go for corneal cross-linking followed by contact lens fitting, or to do intracorneal ring implantation followed by corneal cross-linking. Now let us think about this. Which is the least aggressive? Of course, doing corneal cross-linking followed by contact lens fitting is less aggressive than the other option. Another example, a patient with good vision, good thickness, moderate refraction, significant high-order aberrations, progressive disease, and the patient is intolerant to contact lens fitting. And depending on the other parameters, there are 2 options. Either to go for intracorneal ring implantation followed by cross-linking followed by glasses, or to do corneal cross-linking with customized laser vision correction followed by glasses. Now let us think, which one is least aggressive? Actually, intracorneal rings are less aggressive than the other option. Why? Apparently, you may think that the intracorneal ring implantation is more aggressive because it is an intracorneal surgery, while corneal cross-linking with customized laser vision correction is a superficial surgery on the cornea. And the side effects of intracorneal ring implantation or the complications with this option probably are more than the other option. Actually, the first one is less aggressive because it is reversible. So we can remove the intracorneal rings anytime, while doing customized laser vision correction with corneal cross-linking is irreversible. And any side effect or any complication with this option, the second option, is permanent, cannot be reversed. This is why the first option is less aggressive. This is another example. A patient with good vision, good thickness, mild refraction. His age is 27 and he is intolerant to contact lenses. Depending on other parameters, suppose that we have 2 options. Corneal cross-linking with customized laser vision correction, or glasses and observation. Logically, glasses and observation are much better, especially that he has mild refraction and his age is 27, so we can observe him. Another example, a patient with good vision, good thickness, but high refraction, and his disease is stable, and he is intolerant to contact lens fitting. Depending on other parameters, suppose that we have 2 options, intracorneal ring implantation followed by corneal cross-linking with customized laser vision correction, followed by glasses if needed. And the other option is intracorneal ring implantation followed by phakic IOL implantation. Now, the least aggressive, or the option which is less aggressive, between these two is intracorneal ring followed by phakic IOL. Why? Because, first of all, the first option has 3 steps: intracorneal ring followed by another procedure followed by glasses, while the second option is just 2 steps: intracorneal ring followed by phakic IOL. The second reason is corneal cross-linking with customized laser vision correction is irreversible. Another example, a patient with good vision, high refraction, progressive disease, and he is tolerant to contact lenses. There are 2 options based on the other parameters. They are corneal cross-linking followed by contact lens fitting, corneal cross-linking followed by phakic IOL. Of course, the first option is less aggressive. Another example, a patient has poor vision but good potential vision, good thickness, progressive disease, and he is tolerant to contact lenses. Based on other parameters, the options are corneal cross-linking followed by contact lens fitting, or corneal cross-linking with customized laser vision correction followed by glasses. Of course, the least aggressive is corneal cross-linking followed by contact lens fitting. But please remember that and tell your patient that if we do corneal cross-linking and then contact lens fitting, in the future, if we want to do customized laser vision correction, we have to repeat corneal cross-linking, and if we want to do intracorneal ring implantation, it will be very difficult with unpredictable result. So when we say the less aggressive, it does not mean that it is the final solution, because maybe the patient will come later and he is unhappy with his contact lenses and wants another solution. So in advance, we have to tell him that if he comes in the future and says, I don't want contact lenses, sometimes it would be difficult to find another solution. In this example, the patient has poor vision, but good potential vision, borderline thickness, his disease is stable, he is intolerant to contact lenses, and has moderate refraction. Based on other parameters, we have 2 options: intracorneal ring implantation followed by glasses, or intracorneal ring followed by phakic IOL. Of course, intracorneal ring followed by glasses is the least or the less aggressive. By this, I finished answering the 3rd question, and we finished the 5th step, which is logic thinking. We come now to special considerations. There are special considerations in pellucid marginal degeneration and in keratoglobus, and we have to know what to do meanwhile observation. So let us start with pellucid marginal degeneration. We all know that pellucid marginal degeneration is characterized by inferior thinning, and the cone of the cornea in the cornea is above the thinning, not within the thinning area. This is contrary to keratoconus. So, if we want to go for corneal cross-linking in pellucid marginal degeneration, we have to cover the inferior part. So, we have to go decentered, and of course, we have to take care of the limbal stem cells, but it's very important to be as marginal as possible in order to cover the inferior thinning area. Otherwise, we will not get benefit from corneal cross-linking and the disease may progress. If we want to do corneal cross-linking with customized laser vision correction, it is very important to remember that we have to study the profile of the laser treatment, because as you see on the right side, the patient has hypermetropia, and the profile most probably will be ablating the peripheral area. Now the superior part, in the superior part there is no problem, while in the inferior part, if the laser profile includes the inferior part, it will be a disaster. So sometimes in pellucid marginal degeneration, we cannot do laser vision correction or the customized laser vision correction. The same can be said if we want to go for intracorneal ring implantation. As you see here, the cone is central or paracentral, while the area of thinning is very inferior. So if we want to implant an inferior segment, we are definitely going to go through the inferior thinned part, and this may lead to perforation in addition to lack of efficacy of this implantation. In addition, if we want to implant an inferior segment, we have to follow the rules of the thickness of the cornea, the least thickness that is possible in this area of implantation, depending on the recommendation of the company. The same can be said regarding myoring implantation, because the least thickness that is acceptable in the area of thinning should be 380 microns and above. We come to the option of phakic IOL implantation. Because many people with pellucid marginal degeneration have high astigmatism, we have the problem of the rotation of the phakic IOL. So let us suppose that the phakic IOL was implanted on axis, and then for any reason it rotated. There will be blurring of vision, and we will have high order aberrations, and we have to readjust the phakic IOL. So taking the measurements of the wide to wide and other measurements for the size of the phakic IOL is very, very important, because any minor rotation of the phakic IOL will cause a disaster. Finally, keratoplasty is not that simple in pellucid marginal degeneration due to the inferior thinning, so there are special techniques that should be followed. In keratoglobus, still there is no evidence of efficacy of cross-linking to stop the progression of keratoglobus, because it is a generalized thinning extending to the limbus. People with keratoglobus should be protected by glasses, and even if scleral contact lenses were fitted, protective glasses still should be used. In addition, there are special techniques of grafting. Now I come to the most important point that is most probably missed with many doctors. What should we do while we are observing a patient? Suppose I have a patient and I want to document progression. What shall I do during this observation period? First, itching is forbidden. You have to tell your patient, do not itch. And we have to give him copious lubricants. We have to treat itching aggressively. We have to treat blepharitis aggressively. Sunglasses are a must, and the patient should avoid any irritants. Why all of this? Actually, itching is the main reason of progression. I'll give you this example of a young child. He is 10 years old. He has no family history of keratoconus, and he has no keratoconus. But as you see here, this is the right eye. The cornea is very thin. It is 467 at the thinnest location, and K reading are high, 48.4. The patient has severe itching, and this is the other eye. The thickness at the thinnest location is 453, and the Kmax is 47.8, and there are no signs of keratoconus or pellucid marginal degeneration. But this patient is at risk, so we have to treat his itching aggressively in addition to monitor his cornea every 3 months. Now, let me summarize how to study a case. First of all, you have to follow the 5 steps: suspicion, tomography, accurate refraction, identification of the 12 parameters, and doing the logic thinking. In addition, in order to avoid missing any single information, we have to fill this table. We have to tell whether the case is transparent, the cornea is transparent or not, Vogt's striae are there or not, the case is progressive or not, what is the age of the patient, what is his gender, thickness at the thinnest location, Kmax, amount of astigmatism, here not manifest astigmatism, this is the topographical astigmatism based on the total corneal power map, and his incorrect and best correct visual acuity, potential visual acuity when his corrected visual acuity is poor, and the amount of subjective refraction. After that, we have to classify the case into good vision or poor vision according to these criteria. Then we move to this flow chart in order to know which path I have to follow. But remember, and remember, and remember that the queen of the options is glasses, and contact lenses are its prime minister. Errata. In video part 9, when I mentioned the customized method of intracorneal ring implantation, I mentioned that the depth of implantation should be 80% of the thinnest location. In all cases, actually this is wrong, because if we follow this rule, then in many cases implantation will be superficial, and if the patient has minor itching, the intracorneal rings will protrude and we have to remove them. So let us say if the thinnest location is very dislocated, as in this example, and it is near the path of the tunnel, in this case I look at the thinnest location, multiply it by 80%, and then this will be the depth of implantation. But if the thinnest location is not dislocated, as in this example, in this case I have to look at the thinnest measurement along the tunnels, and then I multiply this number by 80%. By this, I finished the series of keratoconus management. Thank you very much.